Continuation of Omaima notes, part 3. There we have stopped at that. Now, let's see. This is botulinum toxin used for the treatment of achalasia, work by blocking acetylcholine. So, release of acetylcholine is blocked, vesicles of the acetylcholine. Ramipril ACE inhibitors, angiotensin converting enzyme. So, angiotensin 1 to 2 1 to 2 that is prevented by ramipril, so that is used as an antihypertensive. Renin secreted from the kidneys in the liver, angiotensinogen to 1, and then 1 is converted to 2 in lungs. So this ramipril, enalapril, this is acting. Morphine works in which of the receptors? Mu receptor, morphine. Opioid overdose reversed by naloxone. Opioid contains morphine, so morphine is, naloxone is a reversal antidote for the opioids. Proton pump PPI side effect cause ulcer increase because proton pump inhibitors prevents prostaglandins. So prostaglandin is actually protective for the gastric mucosa. That's why gastric and hydrochloric acid ulcers, GORD, that PPI, this is not NACID, this is proton pump inhibitors. So what is there? So all the stimulants, gastrin and vagal stimulation, gastrin, and these three stimulates, they cause proton pump to release hydrochloric acid. So PPI, when blocked, hydrochloric acid is released. So calcium channel blockers can be treated, this is calcium. Nimodipine is a calcium. So intracranial increase IP. So blockers can increase intracranial pressure. Post CABG patient has wound infection. What to give? So this is a big sternal incision is there. So vancomycin, gentamicin has to be given. Drug causing peptic ulcer. This is NACIDs. So proton pump inhibitors are given. PPI. So peptic ulcer is caused by NACI. Drug causing ulcer by reducing bicarbonate, ibuprofen. So NACI inhibit proton pump inhibitors. Mechanism of NACI is causing ulcer by reducing bicarbonate, cyclooxygenase, and prostaglandin. So that is the mechanism. Bicarbonates are cyclooxygenase. Medication that decrease prostaglandin and bicarbonate in duodenum. NACID. Again, NACID, ibuprofen. Please note that prostaglandin is actually protective. Antifungal ketonazole. Antifungal drug is ketonazole, meconazole, iconazole. These inhibit G4 phase in the cell growth. G1, G2 is there. Cell phase. Mechanism of action of antibiotic. So here is everything. Ciprofloxacin. This is acting on the DNA. Metronidazole, sulfonamides, quinolone, trimethoprim. So DNA, metronidazole, sulfonamide, quinolone, trimethoprim, all they act on DNA synthesis. Protein synthesis, this is cell wall. Amikacin, erythromycin, tetracycline, chloramphenicol, aminoglycosides. RNA, RM, rifampicin. Cell wall, meropenem, penicillin, cephalosporin. So penicillin, first is attack on the cell wall. Patient with fracture of orbital bone, diplopia, X-ray is normal. What to do? MRI. So muscle entrapment or what is that? You have to understand that teardrop sign. Complex facial fracture require reconstruction, 3D scanning of the face. Pituitary gland acromegaly. So it can be detected by MRI. So that compresses the optic chiasma. Recent dementia, CT scan. Final aspiration cytology from cervical needle shows squamous cell carcinoma. Cervical lymph nodes are there, enlarged squamous cell FNAC. Upper GI endoscopy was normal. So where is it? It is secondaries from the somewhere. So PET scanning. Wall replacement X-ray spot locations now. So you take the X-ray. Where is aortic wall? Where is mitral wall? Where is tricuspid wall? So third intercostal space is aorta, fourth AMT. Third, fourth, fifth. Aortic mitral tricuspid. Mitral is fourth, tricuspid is fifth, aortic is third. 3, 4, 5. AMT. Patient has scenario hints of pulmonary embolism. CT pulmonary. Chest infection, pneumonia, X-ray chest can be done. Intermittent positive pressure ventilation, tachypnea, hypoxia, C for pneumothorax. Stab in fifth intercostal space, tachycardia. Next diagnostic is echo. This is directly in the fifth. Heart is punctured or somewhere pericardium is punctured. Do in the center, stab in the center. This is echo. Perforated ulcer, erect X-ray will show air under diaphragm. Most sensitive to see air under diaphragm. CT is actually sensitive. Female pregnant trauma patient, abdomen CT, tender fast scan, CT scan can be done. Cancer esophagus biopsy, next step, CT scan. Esophageal rupture, oral gastrographin, water soluble, it has to be done, not barium. After reversal of the stoma, leakage, you want to again do gastrographin, edema. Colorectal cancer, suspect CA colon. CT scan of the abdomen before colonoscopy to rule out carcinoid tumor, CT scan. Intestinal obstruction, colonoscopy does not pass beyond the hepatic flexure, so then CT. Post-operative day at patient is tachycardic with abdominal pain, abdomen CT to investigate biliary trauma. Post-operative patient tachycardia, abdominal pain. So in fistula complicated diverticular disease, CT scan. Hydrated cyst, initially USG, then more sensitive CT. Smoker, 2 centimeter mass on X-ray, no systemic, another 1 centimeter the liver, MRI of the liver to differentiate. Here it is MRI. After ERCP, patient developed jaundice, MRCP. ERCP you have done, jaundice is there, magnetic resonance cholangiopantography. CA pancreas, jaundice, surgeon doing ERCP, unable to locate ampulla, percutaneous cholangiogram, PTC. It means there is obstruction or somewhere, so you have to go from the antegrade type. Mesenteric ischemia, what will you do? Angiography of the mesentery. Ischemic colitis, thumbprint sign. This is thumbprint sign. Ischemic colitis, X-ray sign. MRI for long tendon, ligaments, and so MRI is to be done for ligament, tendon, disc, cervical stenosis, soft tissue injuries. CT for the bones. Scaphoid not seen on the X-ray. If not seen, MRI or CT can be done. If it is not seen on X-ray. How to see C2? C2 is axis, C1 is atlas. Open mouth view. Complicated fracture, complex supracondylar fracture, CT. 3D CT, complex supracondylar. Old age with claustrophobia, person is afraid of or metallic walls, then contraindication for MRI. Do CT. Ankle sprain, chronic, do MRI soft tissue. Ultrasound shows renal mass. Mass is there, CT scan. 39 male left scrotal swelling, varicocele, next abdomen CT to check kidney. Patient with DVT, initial diagnosis best duplex compression, better than venography. Breast mass younger, under 34, ultrasound, after 35 mammogram. Patient with rupture, high risk breast implant, MRI. Patient with breast cancer did therapy on complaint of back pain, bone scan. Patient had microcalcification was seen by mammograph, radiography. What is next? Core biopsy. Mammograph already done, biopsy has to do. Parathyroid adenoma, system B scan. Biopsy for venous ulcer, punch biopsy. If no punch option is there, incision biopsy. There is no option for punch, then incision. Venous ulcer. Solitary thyroid nodule, fine needle, FNAC. Melanoma of the back, excision. Small millimeter can be excised. Healthy non-transplant kidney functioning, DTPA. Kidney function, DTPA. Kidney damage, kidney transplant function. MAC3 is better than DTPA. Scarring is for DAMSA. Now these are the questions. Life-threatening, rupture, spleen, abdominal bleeding, all these conditions life-threatening, proceed without consent. Not at all. Even for no need for two consultants because you are done. Don't have time. Adult dementia and adult need surgery. Consent number 4. Consultants. Adult 4. Adult patient mental health problem needs surgery, mental health action, opinion of psychiatrist. If psychiatrists agree in the scenario, then choice is proceed the surgery. Adult cannot consult. Adult cannot consent adult no unless he is proxy paper from the court. Also doesn't consent for wife. Patient require consent to save the limb ischemia or patient with testicular torsion, consent of the patient. Patient with Down syndrome can understand the procedure. Gallic competent can take the consent. Down syndrome, learning disability, special needs cannot consent. Patient's parent consent. Type 2 has to be taken. 7-year child, femur fracture, needs surgery, parents consent. Child spleen injury, stable but needs blood transfusion. You did consent to, parents refuse, medical court. Now here on religious ground or some ground we are reasoning good. Child spleen injury, unstable, blood transfusion, proceed without consent in emergency. 14 to 15-year-old needs appendectomy, can understand complication. 1 to 16 Gillick competent, if she agrees, proceed with the surgery. Patient 14 pregnant by her boyfriend, she want to do abortion, her parents refuse, Gillick competent. Best study displays forest plot. Randomized trial displays by forest plot. Happening now and observing. You are assessing risk factor, cross sectional. This is a snapshot like cross sectional. What will happen in future? So anticipating cohort, you observe what happened in past, COPD and retrospective. You are doing audit from the group according to policy of your hospital and international standard. It is clinical comparison with the standards. You do review to enhance quality of care, who work and then bad performance in the action, and peer review. You review talking about availability of clinic to do audit for smoker or whatever you did clinic place for your audit, and you structure audit. It is structure. You give appointment, investigation, X-ray for people to do audit. How the audit, it is process. This is about process. You get results, you take feedback about the end result of the audit. It is outcome, end result of the audit. Doing audit comparison of care against the standard operation is standard based audit. Again, doing audit comparison of the care along the standard but mesh expired in hernia, system based. Define capacity. Patient should understand, retain, analyze to make the decision. Number of new cases, incidence. Reject the true hypothesis. Reject the true, which is true but rejected. It is 1. Accept, fails to reject the false hypothesis. Accepting the false thing is 2. Probability, patient with the disease measure as positive result. Sensitivity means probability patient with the disease measure as positive result. With the non-disease measure, specificity. Positive predictive value, you will measure all positive, true positive and false positive. Predictive negative value, measure all negative, false and true negative. Risk reduction, difference between control rate and experimental. That is absolute risk, number needed to treat. One group only, one risk factor, simple t-test. One group, one risk factor disease. Measuring one group but 2 risk factors are t-test. Simple t-test correlation. Measuring 2 different groups, before and after insulin, paired t-test. Measuring 2 groups, same value, 2 groups unpaired. More than 2 groups, chi-square, more than 2. Extreme range of data, non-normal data, 2 groups, unpaired, Mann-Whitney. Normal data, unpaired, Wilcoxon. Extreme range, multiple subgroups, Bonferin group, small group, Fisher. So this is paper 2, surgery, pediatric and all that. So let's go for next pre-operative lab investigation for 5 years. Old child, there is no need. Elective surgery like hernia, GN, pre-operative hypothermia 35, postponed till temperature 36. Elective hernia more than 95, post-operative iron oral. Patient with microscopic hypopropenia greater risk during operation. Increased cardiac output due to hyperdynamic circulation. Elective thyroid removal surgery, pre-operative HIV discovered. Inform all staff over and do the operation. V inflate curve for the renegade above the systolic pressure emptying the limb. Exsanguination. Systolic blood pressure 100 above 100. Treatment of intraoperative heat loss. Irradiation. Hypothermia during laparotomy. Intraoperative peritoneal lavage by warm fluids. Patient did endoscopy, bleeding work, go for laparotomy. Doing endoscopy, there is bleeding, it is not working, go for laparotomy. Can't be used for 24 hours. Fresh frozen plasma cannot be used more than 24 hours. Massive blood transfusion, patient had difficulty in breathing, acute lung injury. Late complication of transfusion is jaundice, warfarin factor 1972, massive emboli, streptokinase. No massive emboli, patient stable, low molecular heparin, used from brain meds to reduce brain edema, dexamethasone, plasma cell used in multiple plasma cell seen in multiple myeloma. Patient fracture femur, got pulmonary embolism, got brain bilateral petechial hemorrhages, fat embolism, antithrombotic hemorrhagic thrombosis. Petechial rashes from the long bone is a fat emboli. Patient long course, long bone stiffness, Paget's disease. Long course, long bone stiffness, blindness. Patient at bilateral swelling, history, recent flight. Flight means DVT. Antithrombin deficiency with DVT. There is deficiency antithrombin, lifelong warfarin. Patient came from China, nasopharyngeal, mobile femoral vein thrombosis, low molecular heparin, DVT, pulmonary recurrent, vena cava filter, patient of warfarin, expected 2 to 3. Side effect of heparin infusion is thrombocytopenia, alopecia, patient with history of cancer. No history of hip replacement, thrombophlebitis, low molecular heparin, 35 days for the hip and 14 days for the knee and mechanical prophylaxis, early walking and all that. Patient with peripheral vascular disease did not above knee amputation, low molecular heparin, mechanical stocking, intermittent pneumatic compression, device stocking. Sigmoid colectomy, low molecular heparin, mechanical compression, hypovolemic shock, loss of fluids from extracellular fluids. Over resuscitation of polytrauma patient may lead to hyperchloremic acidosis. Blood transfusion recommendation 1 fresh frozen plasma, RBC platelets. Intraoperative weight loss is by radiation. Respiratory depression, delay to wake up after operation is respiratory acidosis due to opioid overdose. Hypotension, bradycardia, increased CVP, heart block. Good immediate urine output, sudden anuria 880 block catheter, decrease urine output after 12 hours post-operative due to syndrome. Inappropriate antidiuretic hormone. Post-operative polyuria, increased sodium level, pre-renal. Post-operative pre-renal failure. Oliguria. If there is oliguria, that is pre-renal hypotension. Increase output is antidiuretic. Confused after giving free fluids. TURP, that is the TURP syndrome, hyponatremia. Patient with diabetes mellitus. Patient with diabetes mellitus. Post-operation convulsions, hypoglycemia. 7-day post-operative patient has hemoptysis. This is 7th day. Pulmonary embolism. 5th day post-operative fever, wound infection. 3 to 4 days post-operative UTI anastomotic leak. 0 days post-atelectasis. Patient has respiratory distress after femoral tibial surgery. Immediately respiratory distress, potential of fat embolism. Patient has right shoulder pain, hypochondrium subphrenic abscess. Sterilization of surgical scrub tray or autoclave. Sterilization of liquid and ointments, dry heat. Sterilization of plastic syringe, radiation. Sterilization of plastic formaldehyde. Flexible endoscope, glutaraldehyde. Sterilization sutures, ethylene oxide. Clean wound, risk of relation to antibiotics before 1 to 2%, after no change. Clean wound in relation to antibiotic before 1 to 2%, after no change. Thyroid, breast, parotid, erectile hernia, varicose vein. There is no need of pre-operative antibiotics. Clean contaminated. Percentage is of SSI. This is percentage of SSI is 1 to 2, 20 to 30%. Uncontaminated appendix, gallbladder and all this. This is clean contaminated. Contaminated in relation to use of antibiotics 60. After 15% colon, dirty wounds, antibiotic more than perforated, diabetic, these are dirty. So clean, contaminated, and dirty wounds. These are the 4 classification. How to stop warfarin before operation? Stop 4 days, normally 3 to 4 days. Shift warfarin, low molecular weight heparin, then stop 12 hours before operation, then 6 hours unfractioned heparin can be stopped. Low molecular weight has to be stopped at least 24 hours. No signs of bleeding, start warfarin target. What is INR target? 2 to 3 again. How to manage patient control diabetes mellitus on diet? Minor, no action needed. Major, monitor blood glucose. Here, if elevated, start insulin sliding scale. How to manage diabetes patient oral medications? What is the difference? Start oral medication. If major, oral medication to insulin sliding scale. How to manage diabetic patient on insulin? Continue. How to manage using steroids? So again, steroids 10 milligram. If more than 10 they are taking, you have to give 25 milligram hydrocortisone and continue for 2 to 3 days. Double the dose. When to start enhanced recovery program? 3 to 4 hours before surgery. You have to give high carbohydrate diet. What is the role of recovery? Speed recovery and shorten hospital stay. Mechanism of enhanced recovery is reduce insulin resistance and improve nitrogen balance. How to classify 5 ASA growth? Grade 1 healthy, 2 mild disease, 3 severe disease, uncontrolled. Severe disease, disability, mortality rate is high. Physiological response to surgery, cortisol is always increased, acute phase proteins, insulin, sex hormones are not decreased. Remains unchanged is thyroid hormone, causes dilatory nitric oxide, surgical preparation for thyroid is vocal cord check, surgical preparation parathyroid, methylene blue, surgical preparation for the breast, patent blue, radiomarker, surgical preparation for thoracic duct cream, surgical preparation for pheochromocytoma, alpha and beta block, both have to be given. Carcinotumor octetroid, how to manage arterial bleeding, ligate the artery, how to manage venous bleeding, digital pressure, how to manage multiple point bleeding, diathermy. Cutting diathermy works by vaporization of cell water, snare polypectomy, sealing blood surface coagulation, fulguration mode. Monopolar diathermy, patient circuit from generator to end plate. Bipolar diathermy, patient not part, thyroid or circumcision. Patient liver, brain by CUSA, liver and brain, CUSA. Patient venous ulcer, Paget's disease, venous nipple punch biopsy, venous and Paget's. Patient with breast cyst, scenario, solitary thyroid node, FNAC, melanoma like lesion, excision biopsy, no VAS, no provide. Breast tumor that is not cystic or Paget's, true cut biopsy. Nephrotoxicity by cyclosporine, alopecia associated with azathioprine, diabetes associated with tacrolimus. Malignant fibrous histiocytoma is a commonest variant of sarcoma. Malignant fibrous histiocytoma. Liposarcoma second most common. Renal mets hypervascular. Contradiction to lung surgeries are superior venical obstruction, FEV1 less than 5, cutoff point, presence of mets, malignant pleural effusion. What are anesthetic drugs? Local anesthetic pulp, ring block by lignocaine plane, mechanism of action, block sodium channels, lignocaine complication, cardiac arrhythmia, local anesthetic chest infiltration, bupivacaine, spinal epidural, bupivacaine, fracture for the radius pierce is by prilocaine, carpal tunnel, lignocaine, bupivacaine, wound infiltration, bupivacaine, adrenaline. Muscle relaxants, succinylcholine, depolarizing. This is depolarizing. Drugs reversal of the muscle, non-depolarizing, neostic meaning dantrolene for this. Local anesthetics reversal, antidote is intralipid. General anesthetic which is safe, low blood pressure, ketamine. Local anesthetic which has liver damage, halothane. Hepatotoxic, infected wound anesthesia to use bupivacaine. Patient with scalp wound, Gorotin, epistaxis, lignocaine. With adrenaline, patient to do surgery on extremities, local anesthesia, Beers block, calculate dose of anesthesia, patient weight into percentage and divide by the weight into dose divided by percentage into 10. Side effect of thiopentone. Thiopentone is myocardial depression, porphyria, etomidate, adrenal suppression. Best for hemodynamic unstable cardiomyopathy is ketamine. Side effect ketamine is dissociative. Most analgesic effect is ketamine. So ketamine is better. It has got dissociative and Propofol antiemetic property is there. Drug contraindicated in porphyria, thiopentine, etomidine. And repolarizing is succinylcholine, inhibits acetylcholine. Patient require emergency succinylcholine fastest action. Succinylcholine hyperthermia causes hyperthermia, hyperkalemia, muscle contraction, contractions, compartment syndrome, hypotension, non-depolarizing atracurium, pancuronium. Pain management in the child is paracetamol. Patient given anti-anxiety benzodiazepine. Toxicity sign is flumanazole. So anti-anxiety benzodiazepine toxicity, you have to give flumazole. Patient doing carpal tunnel syndrome, lignocaine, adrenaline mixed with Marcan. Old general anesthesia cause liver damage, halothane. Tourniquet inflation above systolic blood pressure after exsanguination. Opiate contraindicated head injuries. Patient has neuropathic pain post amputation, amintryptaline. Patient has neuropathic pain, hypotension, pregabalin. Patient neuropathic pain in diabetes, duloxetine. Pregabalin, duloxetine. Trigeminal neuralgia. Patient is having trigeminal neuralgia, facial pain, carbamazepine. Bone metastasis, prostate, radiotherapy, hepatic metastasis, NSA, steroids. Suture used in thyroid operation to close skin, stainless steel clips. Suture used in sternum closure is cardio stainless steel wire. Mass closure laparotomy PDS 10. Suture used in large vessels is Prolene 30. Small vessels Prolene 60. This is round body. Suture used to fix strain Silk 30. Suture used to ileocolic anastomosis Vicryl 30. Patient did bed surgery, axial lymph node clearance, drain type, Removac or Radivac drain. Chaisop drain, active suction. Patient did Hartmann's operation, left colon, Robinson drain, passive, non-suction. Common bile duct operation, T-tube drain. Name of the open drain, Penrose corrugated drain. Patient has burn, pain, redness, dry, superficial, first degree burn. No skin graft needed. Patient has burn, blisters, second degree, partial thickness burn. Patient has no burn pain, white, full thickness, third degree burn. Patient had burn, now has hemoptysis, curling ulcer, burn CR, curling BUR, CUR, curling Cushing's stress. Patient burn, now has edema, hypoalbuminemia. Patient has 6 days burn post-op hiccups, acute gastric dilatation. Patient burn, not injured but throat pain and confused laryngeal edema. Intubate this. Patient PAOP, occlusion pressure, pulmonary artery occlusion pressure minus is hypovolemia, plus is cardiogenic. PAOP is less, is hypovolemia. This is increase, is cardiogenic. And SVR is decrease, is neurogenic. SVR is decrease, VOP is decrease, many things are decreased in septic. Heart rate is also decreased, VOP, everything is decreased in neurogenic. Patients BP and BP plus normal respiratory rate. Lost blood 750 ml, urine less than 30, grade 1. Patient BP plus pulse rate is patient BP normal, pulse rate 100 to 120, it is 200 to 120. Pulse rate 120 to 140 is 3, more than 140 is 4. Urine specific gravity in hypovolemic shock is increased. Anaphylactic shock, adrenaline 1 in 1000, subcutaneous intramuscular, antihistaminic, hydrocortisone. Treatment of septic shock, noradrenaline in patient with appendicitis. This is septic hypertension, increase low SVR. Polytrauma patient got hypoxic, log rolling, patient so because log rolling, patient examines spinal injury, spinal shock. First response to the shock is sympathetic. Second hormonal response is renin. Patient with metastatic cancer, biochemical abnormality, hypercalcemia. Fluid therapy. Example of crystalloid, isotonic, dextrose, normal saline, hypotonic is normal. This is isotonic, dextrose, normal saline. Hypotonic is sodium chloride 0.5. Hypertonic is dextrose mixed with lactate, dextrose 10%. Colloid is plasma expander, dextrine and all this. Patient has root traffic accident, need fluid resuscitation. Resuscitation fluid is Hartmann ringer lactate. Sodium 131, chloride is also 130, bicarbonate 29. Patient at shock burn, need fluid resuscitation 500 ml cc 15 minutes. Hartmann ringer lactate. Post-operative oliguria fluid challenge ringer lactate 200 as soon as possible. 10 to 100 per kg. Repeat 4 times. Fluid management for adult 1.5 dextrose, 1.5 liter dextrose and 1 liter normal saline. Fluid maintenance for the child 10% dextrose is for neonate. Fluid resuscitation to avoid free feeding is 10 calorie, low calorie, normally is 25 to 30 kilocalorie. Hyperkalemia, IV calcium gluconate immediately. Hypocalcemia, calcium gluconate, same 10%, 10, 10, 10. When hypocalcemia and hyperkalemia, you give insulin along with the glucose with calcium. High calcium, normal saline. Calcium has to be reversed by normal saline. 3 to 6 liter, and then add pamidronate. Patient has high sodium due to hyperhydration. Now you want fluid restriction, give 5% dextrose. Low sodium, confuse excessive isotonic saline, normal saline. Low sodium, very severe low, give hypertonic saline. Patient in laparotomy, hypothermia. During operation, warm intraperitoneal fluid. Doing no open up surgery such as hypothermia, warm IV fluids. Nutrition, laparoscopic anti-resection, loop ileostomy. After laparoscopy, oral nutrition. Nutrition therapy after head trauma, patient is conscious, no skull-base fracture, tube feeding can be given. Short-term feeding option after gastroesophageal surgery, tube feeding, nasogastrous tube. Long-term tube feeding, motor accident, intracranial pig. Long-term feeding after stomach surgery, percutaneous endoscopic jejunostomy. PEG cannot be done, it has to be jejunostomy. Nutritional therapy after iatrogenic esophageal perforation, TPN, perforation of the esophagus, 5 cm jejunal resection, TPN. Nutritional therapy in patient with Crohn's disease, multiple resection out where TPN. Patient has weakness, bony points, retain statins, hypercalcemia. As per Parkland formula, calculate 4. Actually, original Parkland formula, now it is reduced to 2 ml per kg, give 1. This is the Parkland. Now all blood disease. We'll stop this part here.